The agenda for today's meeting is available on our website, but I will try and be as clear as I can as I go through the agenda. So I'm going to start with apologies and welcomes. First of all, I need to welcome Richard Evans in his role as Interim Chief Executive Officer. This would be his first meeting, but he has an urgent alternative thing that he needs to do. So I'm very pleased to welcome Darren Griffiths in his role as Deputy Chief Executive Officer, Interim Deputy Chief Executive Officer. Alongside that, I'd like to welcome Anjula and Raj as our joint interim medical directors. We already work together, I know, as deputy medical directors, and this unique arrangement, and it is a unique arrangement, gives us the benefit of having both secondary care and primary care backgrounds around the board table. So it's great to see you here as well. In terms of apologies, as I've said, we've got apologies from Richard Evans. We have apologies from Deb Lewis, Chief Operating Officer, but thanks to Craig Wilson, who is attending in their stead. Apologies from Marissa Bourne, Director of Strategy. But again, we've got Karen Stapleton attending. Thank you, Karen. And apologies from Judith Vincent, but we do have Andy here from the Health Professionals Forum. Andrew Jarrett, we have on Zoom, and it's Grant and Anjula's first board as Executive Medical Directors, as I said before. It's not Debbie's last meeting, but it is the first that she announced her departure. But we will have some more opportunity to embarrass Debbie at a future meeting. As I've discussed in our recent reflection of board effectiveness, I do want to be brief today, particularly with the introductions, so that we can have substantive discussions around items. Executives can be assured that we've read the papers diligently and highlight the 3 to 4 key points and things you want us to focus on, so that we can have sufficient time to debate, challenge and seek assurance. I think that's all I wanted to say as a preliminary. So moving on to the other items. I haven't got any declarations of interest in advance. Are there any for today's agenda? No, I'm not seeing any. So we now take the minutes. We've got 2 sets of minutes on the no, we don't take the minutes. We have the patient story next. It's on the wrong set of wrong agenda. So I'm going to ask Gareth to introduce the patient story.
Thank you, Chair. And I'd like to formally welcome Larry Ash board today, and Larry works in our hospital palliative care team. And the story focuses on the importance of speaking Welsh and the impact this has on our patients, and to promote awareness to staff that the Welsh language is important, but always consider when speaking to patients and families. And it'd be great for you to answer any questions after that, Larry.
Thank you very much. Thank you. Thanks, Gareth.
Fy enw I ydy Eleri Lloyd Ash ac rwy'n gweithio fel nyrs clinigol arbenigol gofal lliniarol yn Nhîm Tywyn, y mwrdd iechyd Prifysgol Bai Abertawe. Rwy'n gweithio yn Ysbytai Abertawe ac hefyd wedi gweithio yn y gymuned am flynyddoedd. Mae'r gwasanaeth gofal lliniarol yn gweithio wrth ochr y tîm gofal meddygol ac yn rhoi cyngor a chefnogaeth i'r tîm gofalu ar y wardiau ac i meddygon teulu a nyrsys yn y gymuned. Rôl y gwaith ydy gwneud bywyd cleifion sydd â salwch sydd yn cyfyngu bywyd yn fwy gyfforddus. I fi wedi defnyddio'r iaith Gymraeg yn gwaith ers i mi ddechrau nyrsio. Cymraeg i fy iaith cyntaf, iaith y cartref a hefyd oedd iaith fy addysg. Mae pobl nawr yn cydnabod bod salwch a henaint yn neud i bobl troi at eu mamiaeth ac yn fy marn i, mae defnyddio'r iaith cyntaf yn helpu'n fawr iawn i wneud i bobl ymlacio ac i adeiladu hyder wrth siarad. Yn fy mhrofiad i, rwy'n gweld pobl yn newid pan yn clywed yr iaith. Mae eu gwynebau yn troi'n wen a mae pobl yn cysylltu yn fwy gyda'i llygaid. Mae fel bod nhw'n gweld goleuni a gobaith trwy chaos salwch. Mae gofynion y gyfraith iechyd a gofal yn fain. Felly mae gwneud yn siŵr bod y claf yn deall yn iawn beth sydd yn digwydd iddyn nhw yn hollol bwysig. A mae hyn yn bwysig nid yn unig i'r claf ond i'r bwrdd iechyd sydd yn rhoi'r gofal. Mwyn wneud yn siŵr bod y claf yn cael y gofal gorau, rhaid i ni roi'r cyfle i nhw ddweud beth sydd yn eu poeni nhw mewn iaith sydd yn gyfforddus. Dyw sgwrsio yn y Gymraeg ddim yn ddigon bellach. Nawr, dylai'r claf gallu cael ei hasesiad iechyd yn yr iaith Gymraeg. Mae gen i ddau stori. Y cyntaf yw dyn mewn oedran gyda dementia. Cafodd Mental Capacity Assessment yn Saesneg, traw Cymraeg o Gwmtwrch oedd ei iaith cyntaf. Oedd rhaid penderfynu os oedd e moyn a gallu mynd sythre i'r groten, neu os oedd e gorfod mynd mewn i cartref. Dim ond trwy siarad Cymraeg a wneud yr asesiad yn Gymraeg o'n i'n gallu wneud asesiad cywir a cael y canlyniad priodol. Yr ail stori yw am ffarmwr o Sir Benfro a oedd yn cael triniaeth cancer. Doedd e ddim yn deall beth oedd yn digwydd. Cafwyd sawl sgwrs gyda fe yn Saesneg, ond dim lot o gwestiynau na chyfathrebu yn ôl wrtho fe. Dechreuodd y doctoriad feddwl bod e'n gwrthygu, a o'n nhw eisiau gwybod beth oedd y dymuniadau'r gŵr, a beth oedd yn bwysig iddo fe. Ar ôl gweld y claf gyda'r doctor, dechreuais i siarad Cymraeg gyda fe, a dechrau cyfieithu'r cwestiynau oedd gan y doctor. Dethon ni i wybod bod e ddim moyn gwybod beth oedd ei diagnosis. Oedd e ddim eisiau gwybod y gwybodaeth, oedd e ddim yn gallu newid. Well gyda fe bod ni'n cyfathrebu gyda'i fab, a roedd e'n hapus i'r mab wneud y penderfyniadau i gyd, mwyn bod y teulu yn gwneud y penderfyniadau gorau iddyn nhw. Oedd ei feddwl yn glir, a roedd e'n benderfynol bod e ddim eisiau gwybod beth oedd yn bod arno fe. Os byddwn ni ddim wedi siarad Cymraeg gyda fe, byddwn ni ddim wedi sylweddoli faint mor gryf oedd ei deimladau. Os mae un neges i'w ddysgu gyda'r storiau yma, hyn yw, pan yn siarad â'r claf a chi ddim yn cael llawer o sgwrs yn ôl, rhaid meddwl os mae'r claf yn deall neu'n siarad Cymraeg. Chwiliwch am yr iaith. Edrychwch i weld beth yw'r cyfeiriad ac a ydynt yn byw mewn ardal lle mae'n debygol o fod yn ardal Gymraeg. Mae'n syndod falle rhai faint o Gymraeg sydd yn cael ei siarad ym mhoblogaeth bwrdd iechyd Bai Abertawe. O Llanmadog, Brynmil, Asgeti, Treforys, lawr i Fontadawe a Sylfera, ble mae tyfodiaeth Cwmtawe yn bwysig, yng Nghastell Nedd, Cwm Gwrach a Chwm Afon, Bryn Coch, Alltwen, Rhos a lan at Brynaman. Yn Ysbyty Singleton, ni aml yn cael pobl o Sir Gar, Sir Benfro a Cheredigion yn dod i gael triniaeth cancer. Edrychwch ar enwau cyntaf y claf, a'i enw Cymraeg, a gwrandawch ar yr acen ar lilt tra'n anhangu geiriau Saesneg. Gofyddwch iddyn nhw, i chi'n siarad Cymraeg, ac edrychwch ar eu gwynebau am ymateb. Falle newch chi byd o wahaniaeth.
Well, thank you very much indeed. That was very powerful, wasn't it?
That was brilliant. And I think what jumps in there, not necessarily about learning Welsh, I think that's important, but it is about identifying those triggers and those areas that may get you thinking of an assessment differently and seeking help and support there. Do you find that the people know those triggers in area, or is it something we need to work on?
I think it was worthwhile, especially in the medical profession who do these assessments. I think it's worthwhile us asking, key patient information. Do they speak Welsh? Maybe not just necessarily Welsh, but what's the language that they communicate through? It could be BSL, it could be Portuguese, it could be anything, but I think it's really important to make sure that the patient understands what's going on and to be able to partake in partnership care, really. So I think we could do more at identifying those patients who are not necessarily speaking English and English only. So I think, yeah, it'd be brilliant if we were able to make headway in that direction. And there's so many people in elderly population, South Wales, who do revert back with dementia, with confusion, delirium. There's so many factors that enable them to, would prefer for them to speak Welsh rather than English. So that's what I think was important to say, especially with those two stories. And I can give you more stories, to be honest with you.
No, thank you. And it is great to have you here in person. It does make a difference actually. Because we can ask you, we can ask you questions. Does anybody have any observations? Yes, I've got Anne-Louise first.
Yeah, thanks, Larry. It was, I mean, it's a good story, but I just wonder how much you're pulled away from your clinical practice to be able to speak to people through the Welsh who perhaps their carers, their doctors, their nurses aren't Welsh speakers. Do you have to do that? Because we just don't have enough, do we?
This was my concern. This is why I raised it with the Welsh department, because I did it within my role. So it didn't pull me away. I speak Welsh within my role all the time. But if it wasn't a patient that was under our care, that we weren't involved with, this was what my worry was. Who is in the health board that can do these assessments in Welsh, especially something that's important as a capacity assessment. So this is why I felt I'm not in a position to be taken away from my role. And I think that's why maybe the Welsh department been trying to get a library of professionals to complete surveys to say whether they speak Welsh, at what level do they read Welsh, at what level, in order to hopefully be able to pull professionals from different teams to come in and do these assessments if there aren't anybody available within the treating team. But in the case of a gentleman who was who had dementia, who wanted to go home, a mental capacity assessment had been made, and a best interest meeting had been made, and a decision was made that he was going to go to a nursing home. But when I spoke Welsh to him, he said, well, that would be a travesty, because that's not what I want. I want to go home to my daughter. Unfortunately, he died in Morrison. But I spoke with the bed flow team, I spoke with the consultant and the medical team, social worker, all the people that were involved with his care, and I asked them whether there was a possibility of them going back and redoing the mental capacity assessment in Welsh, and there wasn't anybody available. So I had to do it myself, even though it wouldn't have been necessarily my role to do so, but I did it. I thought it was really important to do so. And then I went back the following day to see whether the patient could recall what we discussed. And obviously with patients with dementia, they have good days, they have bad days. And fortunately the patient wasn't able to recall my conversation from the day before. And unfortunately he didn't, but I felt that he really wanted to go home. His feelings were really strong when I spoke to him and had a whole conversation in Welsh. Whereas previously, people couldn't assess what the symptoms were like, couldn't really assess what his wishes were, couldn't really assess where he wanted to be following discharge, couldn't really discuss where he wanted his place, preferred place of death to be. You know, there were so many elements to his care that really we couldn't get a true reflection of what the patient's wishes were until I was able to sit down with him and say, Shemai. And he turned around and said, Llyfar. So, you know, and then I was able to have that flowing conversation.
Thank you. Thanks, Anne-Louise. Angela, now I've got
I think it's a brilliant presentation, Mary. I think it really highlights that the importance of it. And I think from a clinical outcome, it would have been a totally different outcome for that patient. That is the bit which is striking to me, because he didn't get this right at the time you got it right, it would have been a very different pathway for that patient.
Yes.
And I think the other bit for me was you mentioned that his behavior wasn't what we would expect in terms of how he was communicating to us. Again, are we seeing those signs and symptoms that maybe there is another reason?
Yeah.
And for me, it is really important that we get that message across, that every opportunity we can ask that question, we should ask, and that starts in the community, starts through the time when we're referring patients. Because when we can communicate that to colleagues, this question has been asked about what is their preferred language. And I think that service is in a better position to actually accommodate that. So I think it starts on every level for me.
And it should be an NP assessment form. What's the preferred language? I want at the top to be able to then guide.
Angela. Nuria.
And Ellie, thank you very much. I thought it was really powerful. I think you made a really excellent case, and the experience that you had is really incredibly valuable. And I think Angela has just articulated what I was going to say incredibly well, in terms of you can really see the outcome of promoting the Welsh language. And I think it's that promotion part, is are we getting it right?
Yeah.
And it's around, you know, that active offer in terms of Welsh. I can see you've got the Langad, you've got the Bard, so people can approach you, making it clear as to how that that's out there and who we can identify, which I think is what your aim at was in terms of going to the Welsh language team and saying, you know, can we have more people like me so we can support them?
Yeah, because if I'm not around, then who should be able to step in? Yeah.
Thanks, Nuria. Rina.
Diolch yn fawr. Dwi'n dysgu Cymraeg, wedi dim yn siarad yn rygl.
Diolch am drio.
Dwi'n trio. No, I was particularly, it's a simple thing that we need to have on all assessment forms. Why aren't we doing it, or are we doing it? To ask people what is their preferred language of communication.
You know, say what it was.
Is it on all the assessment forms? Can we check? Because it seems to me it's the opposite. Yeah.
Yes, I got Tom next, I think.
I was just going to say something, I suppose, from
Or do you want me to come to you last?
Yeah,
as our,
right.
as our champion? Jean.
I just wanted to say I had the privilege of Hilarious company at the awards night. And as she was up for one of the nominations, she did very well too. And following her instruction, I have now completed my initial training. So I can get a tick in the box for that, I hope. But one of the things that, as a non-Welsh speaker, other than being able to sing the national anthem, giving away my rugby background, I think one of the things that you are doing is perpetuating people's responsibility to make sure that the patient comes first. And that's evident because the damage that is powerfully illustrated in the training is just, I don't think we would want to think about the potential damage it could cause by the incorrect language being used. So thank you for all that you're doing.
Thank you, Jean. Just before I come to Tom, can I ask, I'm going to ask a question because I think Tom will probably come in with slightly more strategic. I know that we are making better progress with identifying Welsh speakers around the organisation on the SR. But is there an informal, so each team, each clinical team, do they informally know who can speak Welsh so that there's, if we do, and we'll get the answer to the question that we've asked about preferred language, do we know who we might be able to go to? And again, that might be something that we bring back at the same time as that other question, because I think it strikes me there are two parts to this. There's a sort of formal part of polling 12,500 people and getting it all into the systems. But there's the informal part of saying, you know, who do you go to in your clinical team rather than having to pull a Larry or people like a Larry out of other clinical teams?
I think this is we are growing numbers of who speak Welsh, the availability. And it's one of the Welsh language standards requirements really is for patients to be able to speak to clinicians in Welsh to help them respond to it. But we're some way off in providing that. But I think there's some further work to be done in terms of knowing who in the department and thank you. Thank you. Tom.
Thank you. I mean, colleagues have expressed this is something that we've been thinking about from the Welsh Language Delivery Group and certainly for Workforce and OD. And I think, you know, that the point around it being very patient-centred and that the whole kind of patient and health and social care in Wales is really, really powerful. And it's about clinical outcomes as well as, you know, aligning to, you know, it's not about compliance to the Welsh language standards. There's this longer term aspiration around Cymraeg 2050 and kind of, you know, how we can best serve our patients and our community. So it's great to see. I think we acknowledge in our annual report that we're still at the start of this journey. That kind of capacity building piece about how we can develop staff and what kind of environment we can do to better develop staff, to progress from some of the beginners courses and how they can actually progress. I think we have this the same at universities, the same across maybe the rest of the Welsh public sector, but think we're at the end of the beginning, but I think we're happy with some of the achievements, and we were really keen to make sure this a patient story that showcased some of the Welsh language work came to board. So definitely, thank you very much. It's great to see.
Thank you. And I think Adair is going to stay for a while to observe the board, which is great. Thank you very much indeed. Okay, so we will now move back to the minutes. We've got two sets, 27th of July and the 14th of August, which of course was our annual general meeting. So can I just ask first of all for any questions of accuracy, comments on accuracy? Happy with those? Good. And then matters arising not otherwise on the agenda or in the action log? No. And then the action log, all open actions have got a status. And I think the only thing I would comment on is we're going to have quite a busy month in November with sustainable travel, people strategy, estates strategy update, culture of permanent engagement and integrated approach across public and staff to Anti-Racist Wales action plan. And we will also have the workforce resilience report. In fact, actually, that will be part of the people strategy in November, but the action around reviewing that, there's some question about the frequency. We will continue with a quarterly update, but rather than it being a repeat of what is discussed at Workforce and OD Committee, it will be we will pick a strategic theme each quarter so that the board does get to discuss matters. Rhiannon.
On accuracy, I did give my apologies for the AGM, but they're not recorded, but I didn't know whether we do record
Yeah, no, we
apologies.
should. No, yeah, thank you for that. Okay, is everybody happy with the action log? And am I, or with the list of things, strategic items, is everybody expecting to bring those next month, next form? Good. Okay, so I think we now move to my update, which is relatively short this time. As I've noted in the introductions, Richard has now formally taken over as interim chief executive, with the consequent changes to medical director and the new deputy CEO. As Richard makes clear in his report later, this new team are very much focused on continuing the important work that this board has directed and is very committed to, including taking forward what we've heard in our big conversation into our 10-year vision of how we will become a high-quality organisation. Board members will have seen Richard's midweek message this week, and I just wanted to draw attention to that because it provided a link to a document outlining how we will use the One Bay Way to deliver this vision. So we are taking that forward at some pace. Board members will also be acutely aware of pressures of performance and the dire financial situation. This, of course, is mirrored across the entire NHS, but that is scant comfort to our staff who are under immense strain and our patients who are waiting too long. There is a growing consensus that the only way out of this storm is to transform the way we deliver care and the way in which we support the public to keep healthy and manage their conditions. And that far from being a defensive or backward step, this is a huge opportunity actually to embrace digital, to reinvigorate our communities and to empower our public. There was an NHS Confederation conference, and I said this as the chair of that as well. I think there's a real opportunity here. Never waste a good crisis. It is a good crisis. It's really very tough, but we should absolutely be using this as an opportunity to transform the way we think and the way we work, bedded in that work around vision to become a high quality organisation. So on people, really the only thing to mention is the Love Awards this time. It was the most amazing event, as always. I've received lots of feedback. Anybody that went, please do feedback, and we are always looking to improve it. But it gets better each year, doesn't it? What blew me away was not the event itself, actually, it was the breadth of achievement and commitment across the health board in both clinical and non-clinical areas. So the breadth of what we do, the innovation across our organisation is staggering. I find it really inspiring and it made me feel very, very proud and very humble. So back to today, following last month's change to the ordering of agenda, we got good feedback on that, and I think it does give us an opportunity to focus on the important work of committees, so we're going to continue that. I think it's a good opportunity to focus on those committee discussions, particularly given the pressures that I alluded to earlier. So that's all I really wanted to say. Any questions on that? No, in which case I'm going to move to Darren to cover the
Thank you, Chair. We're welcome to stay with them. The overlap with what we've already introduced, but it's important to maintain that level of message, really. And also to comment that Richard would have loved to be here today, but his absence is completely unavoidable with the circumstances of what he's had to deal with. I just wanted to reiterate some of the opening remarks paid to Mark and his leadership, and just to confirm as an executive team and his leadership, we are doing a commitment to the direction set, which is actually important. And we reflect on what direction share. It's really important to say we are continuing with the journey and we are ambitious to deliver that journey. On page 2 of the report, we set out the commitment to the high quality organisations through the big conversation. As you've said, that information is out within the board at the moment, and we're actively engaging in those areas to refine that message and to act on what we've said and what we've heard in terms of people that we listen. From a performance perspective, it's on page 3 of the report. We have unscheduled care there. Huge amount of transformation in that area, which is ongoing. Lots done today, but lots to do. And from an emergency department perspective, we are seeing some green shoots, and some of our performance there is the best levels in Wales at the moment, but we know we've got more work to do in terms of ambulance handovers and the interface between the ambulance and the hospital, which we're looking at. And just to call it as well, that we've that's just the medical part of the system. We've got the surgical part of the system as well. We've spent £1.5 million committing to a new area for surgical assessment, and also another £1.5 million of revenue to increase the capacity in that area to do better for the patients waiting for surgery. And from a plan to care perspective, the details in the report, but just to say that by the end of October, we anticipate having no patients waiting over 52 weeks for an outpatient appointment. That's been a long journey and still not at pre-COVID levels, but we're pleased to delivery for us and the best in Wales again on that. And where we are looking to do better is on patients waiting over 2 years. We've just come into the 5,000 level. And by the end of the year, we need to have fewer than 1% of our patients waiting under 2 years. That's about 900. So there's a journey from 5,000 to 900, which you've got an awesome team working on delivering it. And some important news as well that we've received ministerial support for the Newport Talbot Orthopaedic Theatres, and that support is to the value of £14 million of revenue this journey, £1 million of revenue thereafter. And that's where our significant weights are, not exclusively, but a lot of significant weights are. From a cancer perspective, we've had an internal audit report received the Performance Plans Committee this week, which is a reasonable assurance report. But we know we've got more to do in terms of access times on cancer. In the last reported month, just under half of patients were seen within the target time. I know the target is 3/4, but aspiration was to do better for all. And once the backlog is stabilised, the backlog needs to reduce to be determined best. Then in the session after this to look at our internal governance is to reflect on the findings of our audit to make sure we are we're starting to see page 7 report starting to see the movement of COVID cases, and we're coming towards what could be flu season. So a call to arms there for vaccination for our staff, and in turn that obviously passes on the protection to the patients that we serve. So importantly, works with that. There's lots of information on the website about how we get. We've also started planning for next year. We've you said, Chair, very challenging financial climate this year with £56 million we'll spend for 5 months, which is £14 million of plan, plus more on that later in the finance report when I address that with my hat. But we are setting out that ambition, as you just described, our transformation for next year through our planning process. We can't keep doing what we're doing. Actually, we probably will have to do more with less. And that's the challenge I set out at the launch event of that. Page 7 picks up again more detail on a high quality organisation and speaking of safety within the NHS, which you welcome in that publication. And obviously, our ambition is to be able to create an environment and culture where our colleagues are comfortable to speak up, because we don't know we can't act, and the real ambition there to have that level of openness and transparency around it. There's an update on maternity services on page 8 of the report, and the board and the public will be aware that as a result of staffing pressures back in July 2021, we close to birthing centre group for Power and temporary seats at home business services. I'm pleased to report that we've had a significant amount of work across the organisation and with the team. We're now planning to restart the home birthing service and the Leaf Power Birthing Centre to open in October. But that will be a transitional opening as we test the safety and the design of that to be in a position to open that fully within early 2024 calendar year. And I'm grateful for the work of the team on that. Very positively, part of that success and ambition is related to our recruitment. We've got 14 maternity care assistants joining us shortly and a further 21 midwives. And that's aligned to a £750 million investment made from the health board. So once we recognise financial pressures, we've always invested in quality, and that's a clear mark that we've done that. So important news in terms of the breadth of that service and the offer. On page 8, we talk about the work we're doing with the Carmarthen and Cumber GP practice. I won't go into the details here, but that's a progressing and positive dialogue, probably more to come. And in terms of celebrating good news, there are many good news stories across the report, and it's always difficult to do this introduction and not call everybody out, so I won't call it anybody. I'll just ask you all to reflect on the positive stories and the experience that all of us had when we did our Balance Award, which was very, very important. Finally, at the end of the document, talk about our COVID memorials. Been in the past, and they're still with us, and the memorial gardens have been opened through the course of the summer. The Singleton one, the most recent one, and that creates an environment for our staff and our visitors and our patients to just reflect on the past, really, think of the future and what that holds. So we all wanted to say, taking the lead on to the host inspections, Chair, and any questions and bring it.
Thank you. Thank you very much, Dan. Any questions on the Chief Executive report? Steve and then Nora.
It's not a question, Chair. It's a comment, really. Darren, you raised the issue of maternity. In the Quality and Safety Committee this week, we were made aware of an HIW inspection and report into the maternity service. The report has not been issued yet, so there is a limit to what we can say in public about what we think is going to be in that report. But they've let us confirm publicly that the visit did take place. We've received a letter seeking immediate assurance in respect of 8 areas. An immediate improvement plan has been submitted with lots of supporting information, and we await the feedback on the plan and the wider report. And when we get the feedback on the plan and the wider report is published, the Quality and Safety Committee will continue to monitor the progress against that.
Thank you. Thank you, Steve. Nuri, is yours related to?
It's related to the Chief Executive report on RTT progress, just to acknowledge the progress that we made and also to note the challenges around cancer continues to be challenging. And I just wondered, at a system level, can you give us some assurance we have enough capacity to improve on both and where not? And whether our competing pressures, we're able to prioritize strategically and systematically across the board.
A brief response, because so great to come in. We have an ambition to improve, and we have plans to improve. We've been a little frustrated on the cancer side with the pace of that improvement in the performance levels at the moment. From a planning perspective, we committed significant investment financially this year into going above the allocation we've actually in terms of we've got an improving journey, and the team are working on specific specialty level trajectories. That's great to comment because there's more detail on that.
Yes, from a plan care perspective, as Dan said, we've got substantial investment into our recovery plans, particularly around orthopedics. In terms of the recovery there, we're in the process of stepping up the activity in Albert as part of that new development. From the end of August, we had one additional theatre working. The second comes into place in October, and planned for the third in January. That's dependent, obviously, on terms of the reason we're doing that in the phased approach is obviously because of recruitment. But we are also working with an in-sourcing company. We've just appointed a new company to look at in the interim whether we can actually utilise them. They can bring in staff so we can fully utilise those theatres as soon as possible. It isn't without its challenges. It's not just about orthopaedics. There are a number of specialties where we have significant challenges, but we do have robust plans to get us to as best a position as possible. As Darren said, we would need to get around the sort of 900 mark by the end of March. Our current trajectory that we submitted to Welsh Government is around 1,400 positions, so there's more work to be done there. Probably more importantly, we need to focus on those longest waiting patients, and we do have patients with significantly long waits, and we're now with Welsh Government reporting on those longest waiting patients on a weekly basis in terms of the actions that we're taking to ensure that they are treated. From a cancer perspective, yes, we were definitely below the trajectory that we anticipated. There are 3 areas in particular that are problematic. Those are gynecology, lower GI, which is colorectal, and urology. And there are a range of reasons for that. We have submitted new trajectories to Welsh Government and action plans. We have weekly meetings where we're monitoring with the specialties, their performance, and a monthly performance cancer meeting where we bring everybody together as well to look at the overall demands. There is obviously a balance and a bit of a trade-off as well in terms of us trying to achieve both of those targets. And clearly sort of cancer patients do take priority over others. But obviously we've got our elective streams now in Port Talbot and Singleton, and therefore the emergency pressures that we've got in Morriston at least less impactful than they were previously because of that strategic decision that we take. We need to have those surgical centres of excellence.
Thank you. Jean?
Building on that cancer, one of the things that I was particularly pleased to see was the trackers and multidisciplinary team coordinators being centralised from October. So I think that would be a good measure for us, because what we can see, we can then measure.
Yeah, I mean, they had been evolved into the various service groups, and we picked up as a team that wasn't really well working as well as we'd like them to. So they transfer over next week into the cancer services team, and Derry Markham, who's the lead cancer medic, who's and myself are meeting with the team on Monday just to reinforce the importance that the trackers and the MDT coordinators play in the pathway and the management of the pathway. They have a key role in terms of escalating those patients and putting those patients through the pathway.
The other observation, Chair, was that throughout the Chief Executive report, he emphasises the fact that almost all activities need this system-wide focus and effort. So picking up on your comment about where we find ourselves at, I think we can't lose the magnitude of that demand on our staff either.
Other thoughts, questions for Darren or the team? I'd just like to return to the maternity, linking perhaps what you said and what you said. The 750,000, which is a very welcome investment, and the additional staff. that is going to address, it's not just about choice, is it? It is investing in the service within, we're not just using it to expand the system back out again.
No. Within maternity services, we have a review tool that's called Birth Rate Plus.
Yeah.
And what the 700,000 provides us is a means by which to get to the Birth Rate Plus compliance level.
Yeah.
For our service,
Yeah.
covering community, Singleton and East Talbot.
Yeah.
It's the establishment has been quite static. We've made this investment on top, and that enables us really to, it'll support the changes we've got coming up again.
But it will, and it will help to reduce the risk that we're carrying.
It will. The challenge will still be is employing midwives. You know, and we have vacancies there now.
Yeah.
We have the finances there now to support, and you know, it's something that we've just got to continually keep on top of. And as that mentioned, there we have 21 midwives starting in October. 15 of those are brand spanking new. 6 of those are newly recruited into the service. That'll give us about 100 shifts a week, you know, which will really improve how we're able to manage that. But I think it's important to advise forward the risk will still be there. And it is a risk negative service, so we have to continually support, scrutinise, review, and just be really clear that we provide the best service we can.
Yeah, thank you. And Louise?
Is the 750,000 recurrent, or is it a one-off in order to do something to be compliant with the birth policies?
It's a recurrence and allocated directly to address some issues that Gareth just described. I think we want to prejudge the commentary we get from the report in a few weeks, but that requires further investment. We'll consider that as a team. That would form part of prioritisation and be very keen to support on a quality and safety basis. And we can make other choices elsewhere in the system. Keen to make sure we resource things adequately and appropriately based on the channels.
Thanks, thank you. Okay, I'm not seeing any more hands. No, okay, so we will move on. So the first, it's back to you, Steve, so we're into quality, safety and performance section, part 2, item 2.1, which is key issues report from Quality and Safety Committee.
Okay, thank you. So you've got 2 reports representing 2 meetings that were held over the summer in July and August. And we also had a meeting 2 days ago, which the report has not yet been published, but which I will refer to. So in July, I guess the key areas are the HIW report from last year into the prison, pressure ulcers, and the Ombudsman's letter, which comes up later on today's agenda. In terms of the prison, it remains a risk of 20 in our risk register. It's a health board risk register item now. The response to the report is continuing. There have been issues at the prison with changes in the governor and other changes in personnel. There was a joint HIW and prison inspectorate re-inspection, if you like, in March. And the report has not yet formally been received. It has to go through 2 arms of Welsh Government in order to be finally published. But we are implementing as we go our response to the original report and the informal feedback we've had from that updated inspection. The main challenge that remains is the nurse staffing level. We are under-resourced there. We did not have the funds to resource it properly. Primary care have managed to get some temporary funding to mitigate that problem, but it remains a problem, and that's the key area why the risk is still at 20 in our register. There's been some good news in the respect of the mental health and learning disability nursing structure there, because a transfer of personnel from Park Prison in Cwmtaf back to full-time in Swansea is being arranged. So, and there's some funding being made available for that. So that will mitigate the issue. There'll be more work done, and I think by the end of December, we have a target date to complete actions against all the recommendations. So that continues, but it remains a risk, both to our patients and also to our people that work in that environment. So I'm going to pause for breath. If you want to interrupt, please do. Pressure ulcers have become an issue. Well, it's been an issue for some time. It's now been recognised as a quality priority. There are issues across the hospital estate, but also in primary care. And now I'm going to move to the August meeting, because we looked at infection control, prevention and control across the piece. Pressure ulcers in primary care in the community are part of the risk there. But it's good that pressure ulcers have been added, formally recognised as a new quality priority, along with hydration and nutrition. And so there are detailed and specific plans to address those. The Ombudsman's letter we come on to later in the agenda. That was an initial discussion in the July quality and safety meeting. In August, we had a highlight report from the Singleton and Neathport Talbot service group. And there they focused to an extent on pressure ulcers also. They have a new service they call PUPIS, Pressure Ulcer Prevention and Intervention Service, which is making inroads against that issue. That's a service where maternity service is hosted, and we've talked about maternity elsewhere in the agenda. We've had, over the last two meetings, we've had updates on infection prevention and control. It remains a challenge. Primary care, it's still difficult out in the community, but we are seeing some progress, and we're making particular progress in reducing our antibiotic prescribing, which is one of the causes of some of these infections. Singleton, Neathport Talbot, again, progress, but still some difficult areas, notably in Singleton. Mental health learning disabilities are doing very well, and given the challenge that must be faced by some of their patients, that's a great achievement. Fewer medical interventions, obviously physical interventions in mental health, which makes things easier, but they're doing pretty well. That was in August. In September, the Morriston group came to talk to us. And again, if you look at the statistics which are published, Morriston is behind its ideal trajectories in reducing these infection levels. But it's a mixed story in Morriston. Some of the wards haven't seen infections for months, even a year plus. Others are seeing more infections, and those are typically the areas where we are overcrowded, and where it's difficult to free up an area for decontamination and cleaning. But the team is working very hard at mitigating those risks. And in the August meeting, also, we had an important update on another quality priority, which is suicide prevention. This one particularly focused on suicide prevention among our staff. And there's a very successful project called Sharing Hope, which has been disseminated around the health board. And suicide prevention in the wider community will be on the agenda of a later quality and safety meeting, probably in November. And I think I'm up to date, so I'll stop there and open myself up to any questions that the board may have.
Thank you very much, Steve. Questions for Steve, which I'm sure he will neatly pass on to a relevant executive.
Maybe sidestep.
I just ask about prison?
Yeah.
Because I know we've not got funding, but it's a vulnerable population. And we have somehow got to get some sort of long-term plan.
Yeah, it's a vulnerable population and it's twice the size that the prison is designed for and that our nursing and other service structure is set up for. So, you know, when I visited, there were 400 plus inmates on that morning. It's designed for 250 and we're funded for 250 or 300 perhaps. So we're always struggling there. But yeah, and unfortunately, there have been some deaths in custody recently. I don't have details on the causes yet. That'll be subject to inquests, etc. I don't think related to our healthcare provision there. But nevertheless, there's a focus on the place because of when things like that happen. So yeah, there needs to be a plan. I mean, Gareth is the man in charge of the plan. So
I mean, it just strikes me if it's overcrowding, you know, if it's overcrowding, the fact that it's overcrowded is not that is going to exacerbate. So you know, funding, if it's 400 instead of 250, the healthcare needs are probably more than would be expected by 400 because overcrowding is not good for people's physical or mental health either.
And the inmate population have significant health needs. So
Yeah.
in Victorian days, when this thing was designed for 200 men, there are men there obviously, you didn't have drug issues, which you now have. So every day, 200-300 men go and get a drug of sorts from our pharmacy there, which is a little bit like a fortress because the pills are given out through a hole in a metal door. And those issues weren't thought of when the prison was designed.
Gareth?
I suppose to me there's two parts to this. I think there's the HIW review and a progress against that, and we've got two outstanding areas of red there. One is around undertaking a board health assessment in terms of the prison staff and the prison inmates there. And secondly, around staffing. Now staffing, I think we've got an opportunity to be around that. When it comes to the staff that we started I think it gives us the opportunity then to see what that does in terms of providing extra staff there, and then see what we need on from that. Now, it didn't do. We've highlighted the Welsh Government times now in terms of our ability to manage the extras there, and I think it's something that we need to revisit because our plans are changing. So again, even with the resource that we got going in there, we would still have 100 extra men over and above what the service intended for. So I'd be loath for us to think that while we've done well in our HIW feedback and plan, and it's all going well and a lot better to what it was, we still got this key issue there, which will be something that we need to get underneath. But I would do that once we've taken stock following the increase from Cotown.
That makes a lot of sense. Actually, that is quite reassuring. Darren.
Just to explain the financial context, the prison population is counted as part of a resident population. So a change of 100 on a 400,000 population doesn't trigger a financial flow. So it is very much as Gareth described about looking at the resources we've got, moving that resource around to meet priorities. No waiting for that prison population. And there's discussion scheduled for tomorrow, isn't there, to move some of this forward. So we're on the front foot in terms of that, but it may well be that once we've got that further assessment with that resource, we'll have to bring with the help of resources such as with maternity to support the last push for it to be dealt with. But we have lobbied up the line, and there's no mechanism as such as yet to recognise the consumption of health resources the prison population has as opposed to the broader population.
Thank you. Any other questions on quality and safety committee? No, then I think we will move to the next item, which is the public service ombudsman letter. Gareth. Hazel.
This report presents the Ombudsman's annual letter. It also contains the second round of the report, which the aim to change the culture around complaint handling and for the learning to feature in our beauty candle report that we produce next year and next year. 137 complaints were referred to the Ombudsman last year, of which 19 were investigated. Ombudsman has made 5 recommendations for all health boards to consider and take forward, and requires a response by the 1st of December. We're asking Corporate Safety Council to oversee that response on behalf of the board. I think the most challenging one for all organisations is the resource to investigate complaints and the other complaints resource we have. That's been picked up by Welsh School, and they're going to do a piece of work looking at organisations and the resources required. I think all organisations have some complex cases that maybe we need more resources as well. So we've got a really good relationship with the Ombudsman, and we work hard to try and improve complaint handling and learn from the complaints as well, and learning from to Patient Safety Congress as well. I think those are the issues I just wanted to highlight.
Thank you. Thanks. Do you want to anything, Gary?
I think that describes the situation where I suppose a challenge that we have consistently is how we learn and how we spread that learning, how we get assurance that learning is taking place. And that's something that we can never take our foot off really, because we think we're there, then something comes up again. So it's a constant cycle, I think.
And that's a key part of the public conversation about our vision for a high quality organisation. Thoughts? Yeah, Rena.
Not a question really, but it's a comment. I actually went on one of the Ombudsman training programs online. I found it really interesting. But one of the key things that seemed to me that applies, and I think probably is going through the organisation now, when you look at the number that they've investigated, is the fact of early resolution. Because people get a quick response to a complaint, and they feel they've been dealt with professionally and in a sort of quality manner, then they're unlikely to go further if they feel, and I think leaving complaints hanging around for a long time creates the feeling that people have been ignored, and that's when it will go on.
Yeah.
So I did feel it was very useful in the discussion we had with the staff who were also part of the training about how quickly things could get back out to people, even if it wasn't a full response. It was a partial response until further work had been done to investigate. But the fact that people knew it was being considered, I think, would probably stop them taking it further whilst they wait. So I did think that was a sort of key point that came out, and I think staff were saying, well, yeah. And in a way, it creates less work in the long run. So in a way, that's what we want to do, isn't it? So that's part of the learning as well.
Yeah. Sure, I think that's such an important point. I think firstly, we've got a duty candidate, and we know that's going to help really with our there. But I think there's something about even further down the line, our staff having the confidence to put their hands up and say, do you know what, that wasn't great, and we're sorry it wasn't great, and this is what we're doing to improve moving forward. And like next week, what we talk about is once it gets into a formal process, there's an end point that is the Ombudsman. And we really want to get to a point whereby it doesn't come with a formal complaint that we need to be dealing with. So I still think we've got some work to do there. I think on the duty candidate, a bit of a launch pad to do that. But I just think it's confidence as an organisation to say, do you know what, that one very good. And it's okay to say that, but this is what we're doing about it.
Steve and Louise.
Just to say that the Ombudsman's report actually politely suggests a certain number of areas that our Quality and Safety Committee should cover in our review, and we will do that. So that'll be the agenda of our discussion in report back by December, so we'll do it in November.
Yes, and I think it would be good to bring that back to your report back to the board as well. Thank you. And Louise.
Rena's point about early resolution is well made, but the problem with early resolution is that you have to have adequate resources in order to be able to go back quickly. Because if you go back and park a cock, there is, in my experience, there's the feeling that there is some sort of cover up, and then that makes the problems for Hazel and her team even harder because it becomes more and more complex. So it's absolutely a chicken and egg, and at the moment it is under resourced, and it has been for my entire career.
Well, we're actually doing some work at the moment, and we can see what the reason. Right, and I think that the point around the complex complaints, what we find is, and I could probably list the names now, you know, we've got about 4 or 5 that are quite challenging, and rightly so, and I'm not putting an opinion on that. But with the small resource, that tends to take up quite a bit of how we work there. So we've got a plan to look at how the whole quality safety patient experience resource fits together, where we need to focus, where it needs to sit, and how that looks moving forward. And that could well be not having such a centralized approach, but delegating them to the units more, being clear that we get assurance that they're following what they need to there, you know. So there's work ongoing around that.
It's quality assurance as well. I speak sometimes as having, you know, it is about the common sense touch of saying, I hear you, and I understand what you're saying, and this is part of the answer, and we'll give you the rest of the answer. It is that common sense approach, isn't it?
Yeah.
And that's what we essentially need to quality assure. So it's a good question, Anne-Louise. I think it would be.
And you know, we've been doing a lot of work recently about high performing, high quality. This is central to it, isn't it? Is knowing the experience and the impact we have on people using our services. So we need to see complaints not in any guise of being negative, but how do we improve, you know, and I think we're in that transitionary period at the moment in terms of knowing what resource we need, knowing how Get Duty Canada is going to impact on us, and then see what it looks like moving forward. So we can train.
Okay. Oh no, Julie.
2 observations really. One, I guess, is aimed at Matt. What kind of digital support is there for capturing the data flow around complaints? Are the systems same across the piece, or does each department have different systems? Are they supported by a digital infrastructure?
Yes, yeah, I think so. So we use a system, and not long ago there was a piece of work done on an always basis, so that there's always code so that we can compare now against health codes as well. So so within our health board, we've always had a standardized system so that we can see the complaints across and run different reports. And now there's a national system that we can find it easier to do benchmarking in relation to complaints, themes and trends that are coming up as well.
And I guess my last point is some of it, my naivety being relatively new, is what's the process of scrutiny applied to determine the progression to investigation? Is that something that, dealing with the Ombudsman, they lay down the criteria for movement to investigation, or is it purely driven by the escalation of the complainant himself?
The Ombudsman will take each case on its merit and consider whether to investigate, but they will, they have a complete copy of the health board's complaint file so that they can understand the level of investigation the health board is undertaken and the response is undertaken, and that forms part of their decision in terms of whether then they themselves investigate or whether they feel satisfied the health board has investigated and provided a reasonable response.
And I know this will be a question for the Quality and Safety Committee, but presumably we have a trend analysis information from the Ombudsman of what type of complaints and when they are being investigated. Does that information come back? Or digestion by the committee?
That comes back and it's looked at as part of quality and safety groups out in the service groups as well. So they themselves know which complaints have gone to the Ombudsman and understand why. But also we look at it as a health board as well to understand and look at what we can do. So previously in the rules we did seem to have an increase in complaint handling. So we put on training for the investigators in terms of how to complaint handling. Some of the themes around communication, and that's led to the training that the Ombudsman provides us around communication as well. So from a corporate perspective, the themes are coming out to see what we can do as well.
Thank you, Jane.
Thank you. Okay, let's move on to Performance and Finance Committee. Rena.
Yeah, you've got 2 reports here, one from the July meeting and one from the August. I mean, in both, obviously, we're noting an spend position in terms of where we should be against our end of year deficit 86.3. In particular, obviously there were some risks identified, particularly in terms of prescribing, in terms of the amount of income we recovered, and in terms of sort of particularly the Morrison position, which I'll come on to after. In July's meeting, we particularly was noted that we were going to be one of the pilot sites in terms of this continuous flow model within our unscheduled care. And that we've been looking at the way in which it's done within Southmead Hospital in Bristol, with the hope of seeing this kind of model imposed in Morriston to enable us to improve the flow through the hospital from the back door to the front door, etc. Or the other way around, sorry. The other areas of discussion we had were neurodevelopment disorders, which continues to be an area of concern for the committee. And we're still waiting on the sort of final support really from the Welsh Government in terms of the business case for moving this forward. But the difficulty appears to be there's an all Wales problem with this in terms of having appropriate staff qualified to be dealing with this area. And the same applies within CAMS, which is also discussed at that committee. And there's a real staffing issue in terms of psychology workforce. And I know that we've asked Workforce and Digital Committee to have a look at that for us. Cancer, which we referred to earlier, which again is one of our deep dive areas. And one of the things that we particularly were asking for was to have more assurance in terms of the governance of cancer within the organization, which I know Craig's got his hand. And then we come on to the August committee. As I said, the financial position continues to be of concern, and particularly with regard to Morriston. And as a result of that, in the committee this week, we had along the Morriston Service Group team to actually give us more in-depth insight into their issues and where their position is and what they're likely to be forecasting for the end of year, which means that the risk rating is obviously needing to be reconsidered in light of that. We similarly, as I said, I referred to cancer, and we were given some assurance about the new arrangements for the Cancer Improvement Board, which is going to be chaired by our Deputy Chief Operating Officer. We have some good news in terms of obviously the reassurance about the additional monies for the orthopaedic theatres in Talbot, and the additional money for endoscopy, which obviously is currently being run out now. We had the first report to the committee on the estate side. Members commented on what, in a sense, would be helpful in terms of what information we needed each time on estates. And I think the intention is to actually come forward regularly with a report on that. And the last thing on that report, I think, was theatre performance. Again, the committee noted the vulnerability around anaesthetics in particular. And that is an issue, I know, for the orthopaedic theatres in the Talbot. Because whilst we've done very well on recruiting staff generally, that remains an area of concern, because obviously we're having to, I think, outsource and in-source on anaesthetics at the moment. I think that's all I can say now. But any questions, I'm happy to try and deal with, or Darren will help me, Craig. Thank you.
Thank you. Thanks, Rena. Questions for Rena? I mean, we need to talk about the finance, but I think we can do that in the next section. No, I mean, it's good news about some of the planned care. Planned care performance and targets, but there are other areas, and it's good to know that you're all over it. Okay, I think. Yeah, comment. Yeah, of course. Yes, please do.
The shape of the Health Defence Committee is changing a little. I would welcome the estates matters, Susan.
Yes.
I think some of the estates matters have been either directly arriving at board or perhaps going through the routes. The feedback from the committee on what was more of an operational estates report around some of the more technical areas was very welcome. But also recently this week, and we'll have further updates, we'll be able to take some of the smaller aspects of the building blocks of the estate strategy through the discussion around disposals. And I just find the having that challenge and scrutiny from the PSC before bringing them to board ratification is a really important part of our governance, starting to link some of these things together under the strategy, which obviously will bring back in November as well.
Yeah.
So to welcome that.
No problem. Sorry, Andrew. Oh, yes. Andrew?
Yeah, thanks, Chair. I did have my hand up, put it down. I thought we'd moved on. Yeah, I was concerned to look at the information around neurodiversity and the CAM service. The report highlights the issues around staffing on both. I wondered whether at some point in the future, Chair, we could have a bit more information on what the impact is on patients of those staffing issues. I think it's important that the board has some transparency around that bit.
I think that would be entirely appropriate.
Thank you.
Craig, can you just give us a bit of an update on CAMS?
Yeah,
What we're doing?
Yeah, I mean,
I know that would be from an operational perspective.
Yeah, from a CAMS perspective, obviously, we'll be aware that we actually inherited a position from Morgano. I think it's fair to say that the extent of the problems that we inherited were probably greater than we anticipated. As been highlighted, the service at the moment is heavily reliant on agency staff in terms of particularly the front end, the pathway of the single point of access. At the present, I don't think we're reporting formally our performance through to Welsh Government, because I think they realised that obviously we need to take a few months to sort out the issues within the service, and they're ongoing, but clearly recruitment forms part of that. Pathway is quite complex in terms of that there's a 28-day target for first assessment, and then there's also a 28-day standard then in terms of actually putting a CPT package treatment in place. And if you front load the one end of the pathway, you end up with a problem in the second end of the pathway. So it's about trying to find that balance. So yes, performance is far from where it requires to be at present. Okay.
Thank you. So picking up on Andrew's challenge around the impact on patients, is that something we can think about? Can we do that? It's quite tricky, isn't it? I think we can take it away. Something like it might go through quality and safety group or and it is something that I want to keep us focused on. We thought transferring it was going to make a difference, and it will, but it needs to be. Okay. Just one question from me, and it was just it's perhaps something to take away. How is you mentioned it in your update, really. You talked about the issues in relation to workforce in a particular area, and you asked Workforce and OD Committee to look at it. Are we sure we're doing this referral around? What we don't want to do is to bounce issues around committees, do we? And I just wonder whether we should be just take a look at that, because it needs to be quite a strategic thing, and whether we keep, if there is an issue that one committee is looking at, and there's a part of that that's of concern, it comes back to that committee. But I just think we can take that, we can take that and have a think about it. Yeah. Would do it as a matter of course.
I
Okay.
think it's just,
Right. Right, fine. No, okay.
But certainly, I've checked in relation to workforce, if there are particular areas, I certainly do think it should be part of our, I suppose, workforce strategy,
Yes.
where we know there are areas where we can't recruit because for whatever reason, there are not people out there. that we should be looking at what other options are we doing, and maybe getting perhaps some feedback from Workforce and OD as to what we are doing to recruit in those areas, you know. So we've had examples of that recently, haven't we? And here we've got examples today.
Yeah, no, I think that's good, that's well made. Okay, right, so we're gonna move on now to the finance report. Darren, you're on the hat.
Thank you. I'll do the overview. We changed the format of the report for just to try to condense the key messages at the front of the same level of details in the appendix, speak million questions later on. This report is for month 5 August. In the month we spent about £10.2 million against the plan of 7.4 million, so 2.8 million off plan in the month, which takes the health board to cumulative overspent to date of 56.5 million overspent against a plan of 40.6. So we're 15 million, 16 million off that particular plan. At the top of page 4 of the report, you see the usual graphs which track progress. So whilst we were off plan in month 5, it's our best month to date, 100,000 better than the previous months. And that does mask, to some extent, some of the improvements that we've been anticipating and have welcomed around variable pay. So we have seen a positive movement in the pay there. It's from 2.3 million spent. The last 1.3 million, this was £1 million improvement in pay. And we're tracking with a huge level of detail, particularly the level of agency being deployed in the organization and the trajectories that will continue to improve. As the agreement right in, probably a couple of months behind where we thought it would be, just due to get some registrations through, etc. That's working through and being deployed in an intelligent way. At the bottom of page 4, we distribute there the delegated position and where the overspends and pressures are. Chair of the overspends committee has highlighted Morrison's main area of concern, £18 million overspent after 5 months. And we're working with those and the actions in the report. And these put out at Singleton next at 4 million to date, of which a third of that is related to prescribing. And we're seeing an emergence of prescribing pressures. We plan to be 3 million over by the end of the year. Based on the first 3 months of data, which data is 2 months in arrears, that could be as high as 6. And we're just trying to get some really granular analysis of that. Now we've got a quarter's worth of data to understand. But what that table shows then is the delegated position of the board, the money I give out effectively is 22 million overspent after 5 months. Then the bit we hold corporately, the plan was to be 40.6 million over. And to date, through active management of some investments, the business opportunistic events from the balance sheet, we've offset that by 6 million, and that's what comprises the balance sheet. Tell it another way, income's 1.3 million pounds overspent, stabilised in month. Pay 8.7 million overspent to date, and this recalibrated number isn't stable yet. Non-pay 7.6 million overspent, that's largely on theatre consumables, energy, and the prescribing pressures. Savings 4.5 million underachieved, therefore driving the overspent. The plan sits there against the 40.6, and I've offset that by 6.2. So that's not immediately jumping out of the report, but just gives you a sense of key areas. Further into the report, then just on savings on page 7, sharing a weekly update with members of the performance plans, getting the tracking of this. Table 5.1 in the middle just shows there 22.38 million pounds of savings delivered. At the time of writing, that's at 3 now. All of the shortfall is now sat with the Morrison group, and we're working through that with them. Everybody else has achieved what we asked. That's the highest savings delivery in Wales. By the end of this month, which effectively will be tomorrow, we set a deadline for the delivery of the current aspects of the plan. So that 12 million you can see in table 5.2 there, currently about 12.5 million. Expecting some substantial movement on that as teams work through their governance processes this week to convert some of their in-year savings into the substantial economics. Largely because that's related to vacancies, and we do the impact assessment of the decision before they transact. In terms of capital on page 8, that describes a risk of 3.5 million against the 35 million plan for this year. That's 9 million discretionary and lots of other good things we're doing around cladding, environment, etc. I think it should look. There is a fair degree of comfort that that 3.5 million will land. So we're not reporting a heightened risk of capital. We're suggesting that'll be balanced by the year end and managing the various ebbs and flows. The balance sheet items are set in terms of cash. Cash will become an increasingly important debate for us. How we understand what the financial management of the wider system is with year end. And I know that the chair quotes to me the money runs out on the 7th of March, which I'll remember as my birthday. But a very serious point of but
Yeah, I mean, it's got way back into February now.
you probably can bring it. But having not had to report that concern last year because of the great new nature of the board, obviously, as and when I understand more about the need for strategic cash, I'll be raising the board of that particular question.
Yeah.
Two other things I just wanted to mention, one's hidden in the appendix, is that it's the first time I've reported the performance of our contracts between boards, because we need a good quarter really to establish that. On page 15, shows how we're performing as a provider of services, ISOs and board level. And based on the current contracting mechanism, we're over delivering those contracts to the tune of nearly £1 million. So that would be money that come into the organisation we weren't expecting to get. Over the page, this has the commissioner of services from others, and at the moment others are underperforming against what we wish to commission from them, and therefore I will be withholding money from those contracts to the value of £3.5 million based on where we are today. That does change through the course of the year. At the moment, that's not a financial impact that's factored into any of our plans. That's something that's emerging. And obviously, every number that drives that is a patient treated or not. So the motivation there is still to treat the patients, but the financial manifestation of that could be beneficial. In terms of the overall risk of the plans, it's a key point related to Constantine Cadwell and Morriston. We're reporting £24 to £25 million risk of delivery against the 86.6. And with a reasonable degree of comfort, I've been able to work through some opportunities to either slow investments, postpone investments, or look at balance sheet opportunities to largely offset some of that value, subject to lots of other. Because of the change now in the forecast outlook from Morriston, based on a reassessment of the old moving parts over the last few weeks, and with the new leadership team coming in, and the changes in prescribing, I've readjusted that risk up to 41.7 million, which is 15 million at Morriston and 2.7 million of prescribing, which now takes the management that I have available to me to not be sufficient to meet that kind of risk. Therein lies a conversation about the risk. Allied to that is we anticipate in the coming weeks we'll be given a different deficit target by Welsh Government as part of our contribution to NHS Wales, and actually as part of NHS Wales' contribution to the wider government position. We don't know what that will be yet, but I would expect that to be probably somewhere between 10 and 20% further reduction for us, but we'll wait and see what that is. My advice to the board based on that is we have another 6th position emerging towards the end of next week. Around about that time for maybe slightly longer, we'll have a sense of what the stretch asking possibly a new number for us will be in that order conversation. And at that point, I'll have completed the line-by-line review of our opportunities and litigation, and I can bring that for the relevant committees and we can discuss the government's checks. Maybe with the briefing as well ahead of that, understand where those choices sit in terms of the 86.6 million extant plan, anything we may need to do to go beyond that, the level of risk that sets, and how we want to describe that then as well ourselves.
Thank you. Thank you very much, Darren. That was very clear. Any questions for Darren? Steve?
Darren, we heard from Welsh Government or NHS Executive a couple of weeks ago that we, along with I think all other health boards, will be under enhanced monitoring for financial performance. How is that manifesting itself?
So there'll be no change in terms of weekly rhythm of discussion. With that, I meet with the finance arm of the NHS Executive weekly. That's an informal but honest exchange. And I think that helps to provide the understanding collectively of our position. We have routine delivery monitors for the integrated quality planning and delivery meeting with Welsh Government, which is now in 2 parts. It's the quality agenda and then it's the escalation agenda. And I've noted that the next one in October, finance has been added to the escalation discussion. I think it's helpful that the conversation of the money is going to be held in and alongside the discussion around performance delivery, quality and safety as well. So at the moment, the only change in process will be the more substantive discussion. Typically around this time of year in October, we undergo a formal 6 months review of position projection. I'd expect us then through that process an accountable officer letter to describe our robust forecast of the year end in the spirit of that scrutiny and that challenge. And that's what's happening at the moment. I suspect that when we know more about any stretch for us, there may be a different rhythm of exchanges and a different granularity planning.
Do we have a date for the? Is it right? So it would be good to have our internal discussions before that, it may not be possible.
We don't yet, and I don't anticipate that the full exactly cause the sixth number,
Fine,
which has been up for the vetting plan early November.
yeah, fine, okay, fine.
That needs to be done across all systems.
So, I've got a hand from Andrew.
Sorry, Chair, you come to me.
Please.
Oh, yeah, thanks very much. Yeah, thanks, Darren. So we're 15.9 million away from where we thought we were going to be as at month 5. But the health and care services are under huge amounts of pressure at the moment. I just wondered about whether you've spoken to other colleagues and other health boards and whether we're out of kilter with what's happening across Wales. And I only say that because of the huge pressures that health boards are under at the moment to deliver services by Welsh Government. So just wondered whether you had any indication whether we were outliers as far as this is concerned or not.
I don't think that we are. There are numbers in the pack. So there are some boards projecting significantly higher overspends than others. We did a collective and very open moderation exercise in August where we just looked at actions that everybody was taking to land their forecasts. A number of health boards are off plan as we are. And what was interesting through some of those sort of analyses, and I'm probably not speaking out of turn here, is that some of the things that we've chosen to do in a very considered way, like management of vacancies and no blanket ban on recruitment, others have considered and are in the process of implementing. So I wouldn't, by way of a generic example, wouldn't want to not recruit to a clerical post if it meant we'd take time off to clinical people. So we're doing that in an intelligent way with a very clear focus, and we know where the pressures are. The paper shows you we know where to go. And in terms of those actions, as we're managing the things that are truly variable, largely the NHS is on a very similar footing. But I think part of the concern is that the combined forecast of all organisations is around 650 million off. But the trajectory, if you just multiply month 5 by, or divided by 5 by 12, is substantially above that. And that's where some of those things bite in. So a very similar landscape, apart from obviously powers who have a different set of levers in terms of the nature of their organisation.
Yeah, thanks, Andrew. So I think where we are is very challenging. Some green shoots that actually are higher risk, probably. But we're not at this point. I think what you're suggesting is that we wait for month 6, we find out what the additional ask is, you do your final looks, and then we will perhaps, so there may be a need for a board discussion before the next board meeting.
Yeah, absolutely.
Yeah,
Exactly.
okay. Okay, thanks very much. Let's move on. Just to give you a sense, I'm aiming to finish at 1 or thereabouts, which is when the comfort break is. Are people happy with that? Yeah, great. So we've now got the Q1 progress report, the annual plan, and let's kick out that.
Thank you. So this will be the first time that the board will have seen where we are against our annual plan. Although Management Board and Performance and Finance Committee did have a separate update in July. And I think this is the only period when we have a lag because there's no August board, so you're seeing it a bit later. So people will be aware that the board approved a very ambitious plan in March, which outlines our journey towards becoming an excellent high quality organisation. And the plan outlined our route map to get there. I think just to emphasize, the plan is always as a point in time. And people will know that our plan is a system-based plan. So we look at the whole system, cancer, UEC, plan care children. So the report you've got today covers the position at the end of June, which obviously is slightly out of date now. But what we've always tried to do in this plan, it shows where we are against our goals and methods. So what we want to do and where we are on the milestones we've set ourselves. It shows us where we're off track against those, mitigating actions and how we're going to revise those and get them back on track. But also this report, this is what makes it a bit bulky and busy, is it also shows the impact of what we're doing. And over many years we've worked with the board, they want to see not just what we're doing, what's the impact on our outcomes and performance. And our previous chief exec really drove that, getting ourselves outcomes for everything we're doing, let alone the ones that we have to do to achieve the Welsh Government set performance targets. So an example of that would be virtual wards. We've got a whole database dashboard behind that, which shows what we're trying to achieve from that. So the report is busy, and I recognise that there is a requirement to try and sort of streamline the report. But what we're trying to do, I suppose, in the next period is work with the board on that. So reporting on the plan is a statutory duty, and we want to draw attention to the ongoing work to try and streamline the governance arrangements that sit beneath the plan, so that when the plan comes to board, and you'll see this coming through probably in November, we're hoping to slimline what you get, because we'll have done some of that work. So what's happened in the recent period, that we have introduced an annual oversight plan group. We haven't had this in place before. It first met in August and it's due to meet again in 2 weeks. It's been chaired by the coup, and the risks and the mitigations, but it's going to go through that board first. So that group, that board will have directors on it, and they will do that first level scrutiny, look at the risks and mitigation, so that what comes through then to Performance and Finance Management Board should be a slimmer version. So I think the role of the Performance Finance Committee needs to change in that respect. But also we have a board development session in October to work through what that means for board and what we want to see in the reports going forward, taking on board some of the lessons from Deloitte as well. So as at June, the report you've got in front of you shows that we're 58% on track, 13% off track. The appendices show the mitigations, the actions, and what we're trying to do to address that. I suppose the Q2 returns are currently being compiled. And so again, the report you'll see in November will start to look a bit different, because we'll have that lower level of scrutiny overseen by the coup and directors that will take place and take some of this out. So it looks busy. We do have to report and send all this to Welsh Government. So lots of good progress being made. I think first appendice shows the achievements, it shows the ambitions that we're trying to do, off track in some areas, but hopefully you'll be assured mitigations are in place, and the report you'll see in only 2 months' time will look a bit different.
Thanks very much, Karen. Any questions? You're
I had a question on the mitigating actions in relation to population health element being off track. So in particular, the mitigation actions of population health strategy cover lack of capacity and leadership to take things forward. So I've got a very straightforward question, which is just assurance that there is hard action in place or being planned to fill those gaps and drive this important work forward.
I think that's the right question to ask. I can't give you assurance at this stage. It is something which will be considered by the Population Health and Planning Subcommittee at this next meeting.
A number of business cases have gone through our business case assurance program in the recent months to start to build some of that capacity, and some of those have been approved. But I think we recognise it's an ongoing journey to build that capacity to help us become much more of a population health-driven organisation. And we're working closely as teams, aren't we? But it's not there.
I think this goes to goes to the heart of, well, what does it mean to be a population health competent organisation? So there are some business cases that have been approved about delivering particular programmes, which are not yet funded or enacted, and we are making some progress in that, albeit slowly. But in terms of supporting the overall competence of the organisation and getting to the nub of what it means to act in a way which is driven by population health strategy, and brings our activities and our approach in line with population health aims that we've subscribed to, I think there is an ongoing discussion required about that. There are some discussions going on with service delivery groups, and there are varying levels of engagement at the service delivery groups, some very positive, and we're having positive conversations with particularly primary care therapies group about how they can contribute to changing the way that they approach service design to look at delivering population health goals. I think Neath Talbot and Singleton Service Group are another group who have engaged with us in dialogue about, well, what does it mean to work differently? We're finding that other service groups are not as engaged. Although with the change in leadership at Morriston, I think there is a potential that we would have an initial conversation with them shortly. Mental health and learning disabilities are proving reluctant to get involved in that kind of conversation. But then there needs to be the other conversations, which will sit in the population health and planning subcommittee of the board around, well, how do we organise the way we approach planning and delivery to bring ourselves in line with what we've set out our ambitions in the population health strategy. And that also aligns to the One Bay Way and the vision document, where there's a bold statement at the top that population health will inform everything that we do. So I think it's not that there's no work going on. There is work, clearly there are conversations and work going on, but in terms of progress, it is painfully slow, would be my assessment. So if you're looking for assurance, I don't know if that's reassurance I've offered you, but I can't say that there's assurance there.
Well, actually, I think you have given some, I mean, they're talking, it is about the One Bay Way, it is about the vision, isn't it? But the fact that you've gone around the divisions, the units, and talked about who's engaging, and then I suppose the next question then is how do we engage those that don't see the need, and that comes back to the vision and the implementation, because this is a cultural change, isn't it? And cultural change is generally painful. I mean, am I being overly optimistic here?
No, I mean, you're probably acting as a useful counter to my inherent personality. I mean, it is about it, but the elements of cultural change are, changing the language, which we're seeing some change in language and engagement with the concepts, change in attitudes, which, as I said, we've seen in some service groups, but not in others, and then changes in behaviours and then changes in actions. So there is a marked change in discourse across the system, and population health concepts are now talked about routinely, which, you could say, well, take that win, Keith, and shut up. That is a significant difference from where we were even 12 months ago. But in terms of then seeing change in how we organise and deliver services and how we assess outcomes and demonstrating success, we're still some way off that. And that's what we need to. Until we get into that, we're not actually delivering anything differently, are we? So that's what we need to retain our aspirations to do, to see our change in how we deliver our services and see the dial shifting on our population's health. And until we see that, we're not successful. Although we may be putting in place the elements for future success.
You want to come back? No, okay,
There is a lot in there to unpick in the discussion you just had. I think there is some mitigations, because as it stands, the mitigation at the moment is just that leadership and that, but those discussions are part of the mitigations that you're taking. You're right, I do take your point in terms of the bigger picture, and the direction of travel is not quite there. In terms of having a full set of mitigations, it might not be what you would like it to be. I think this is probably a discussion for the population
Yes, it is, and it will be.
committee, and I think it would be really
and it's really on the agenda, isn't it?
unpick.
We teed up for that committee in November. So
And I think it'll be useful to unpick what that looks like in practice in terms of the discussions and what the outcome of those discussions is in reality. And then we can have a clearer sense of some of those mitigation actions. That would be my, but I'm not the lead on this, so I'm just asking the question.
No, it's right. As I said, right question to ask, and clearly, we need to come to a shared view of what it is, because there's some discrepancy. And probably the truth lies somewhere in between.
I think the truth lies somewhere in between is where I'm coming from. And I think it's just unpicking where we are at now and how we can get to that mitigation action being exactly what it will do to then enable the population health to be pushed forward.
I think that would be very helpful. And I certainly do feel, I personally don't feel that I am unsure what sort of governance arrangement we have in place to oversee this. And in a way, given it is such a cultural change and it's part of our sort of bigger picture, in a way we need to have those sort of basic, building blocks, it seems to me, in terms of governance to get this moving. And maybe I'm missing it, but I don't see that being there yet, or I've not had enough visibility of it, maybe. I mean, Keith, I don't know, but I just feel as if, is it embedded throughout the organisation? That's what we need, isn't it? It's embedded within our organisation, but also embedded within the partnerships arrangements we've got, particularly with the local authority and with other organisations, frankly, influence the determinants of health. So I don't know whether it is there, but I think it would be useful to have a discussion about them.
I think we will have that at the population partnerships.
Essentially, that's the discussion that the next population health and partnerships subcommittee is going to be having about where are we now and where do we need to focus our development.
Which one I am, so on. Okay, I think we will move on to the integrated performance report. And Darren, I think if we can just cover things, we've covered quite a bit actually, haven't we? If there's anything that you just wanted to draw our attention to that hasn't been debated, I'll leave it to you.
Thanks. So that was very quickly, page 2, Bridget, we covered good progress in 4-hour community access and long waits in the department, but daily challenges around we touched on cancer escalation. There's more for us to do on that, and we know that's our challenge. Some of the other things that haven't come out of the discussions is our response times for ambulance medical remain. We're not at 65% yet, which we achieved in June. We remain prominent in Wales in terms of how our system responds. That is a system response target. Clinically optimized patients is no matter whether it could be graphs, quite interesting graph this month in the sense that we have the clinically optimized patient beds in Singleton. So page 26, if anyone look at that, which is part of the AMSR plan. We have seen a little bit of a kick up, a noticeable kick up in terms of clinically optimized patients at Morriston Hospital, and that then forms part of the ongoing debate that we're having about just had a perfect fortnight at Morriston. We can understand the findings of that around clinicians at the front door will be proactive and lots of other things that are going on, which colleagues can embellish if that was something they invested in. We picked up infection control, we picked up plans care. Just a little diagnostics on page 34 of the report. With endoscopy started and we've still got a bit of a tail in terms of imaging, and some of those things will be having an impact on the cancer pathway as well. Not the 8-week waits, but the demand in the diagnostic systems around pathology, radiology, and endoscopy will be factors that we will be cognizant of that the solutions are being with. And there's a little tail in terms of people waiting for a therapy intervention of 14 weeks. 15 speech and language therapy, 25 dietetics, but we had that discussion in the service group review yesterday. We're showing progress in that. Stroke beds, on that today, we're just up to 25% of patients having a direct admission to stroke bed in 4 hours. That's progress, but it's not where we need to be. Again, part of the front end of the system and protecting beds for access. Mental health, adults is okay. We picked up on discussion on plans and development. Perhaps just to call out, we had a never event reported in August, which was a retained object. That's reported on page 45. And 1 of 10 incidents reported in that. Our incident reporting has improved. Sickness absence. We've had the second month of a rise in months, so we got down to 6%, which was an improving trajectory. In June, we saw that go to 6.2. We're closer to 6.8 in July. I think the keep an eye on that in terms of where that is. And taking the chair for this one there because we'll be behind.
Thank you very much. Any questions for Darren? Yuri?
I have a very quick one, which is around clinical optimized patients and the change in the definition. And I think it's just assurance around monitoring improvement. The change in the definition will result in improvement. I'm not sure improvement is the right word or description there, but just assurance around when we see these figures in the future, will we simply track actual progress on the ground on a consistent basis over time?
I'll ask for colleague support on that. And if Craig, you will please, because Craig's on the place. We'll come back to you. We did have a detailed update on UEC and tracking of the last 24 months or so was the definitions within that. But we'll get you a sense of whether that's still.
Any other questions? Can I just ask, I mean, never events by definition never happen. I'd like to ask it anyway. Do we have a good disseminated process for ensuring that a particular type of never event does never happen again?
Of course, by which we share learning. And if you think of one of our services where we had probably 3 never events in a number of months, we had one of the summits with them to go through the processes and the issues that have caused the never events. So We have a robust process of investigation with positions involved. We have a robust process of sharing the learning. And when we focus hotspots, then we have a sort of having individual sessions with them to ensure that the learning is disseminated by.
And also more widely than the particular area as well, so, yeah. Great, okay, I think we are therefore finished that section and we will take a break for lunch. If I could see all members back at, we say 1:20, otherwise, very much time, 20 minutes. Next 5 over what was in there. Great, excellent. 1:20, lovely. We go on to live stream. Chris? Yeah, okay, excellent. Okay, welcome back. Thank you very much. Right, so in part three of strategic items, we have nothing this month because we're going to have a great deal next meeting. So we move on to part four, people and digital. So the first item is the PSU's report from workforce and digital.
Yeah, thank you. We've actually touched upon a number of these already today. So I'll take the Welsh Language Delivery Group update. As you can see, you know, I suppose not in contrast to the amazing patient story we had this morning, but I think it just reflects some of the challenge of how we continue to scale and develop our Welsh language capability for the Health Board. So, you know, there is very clear aspiration. I guess there are challenges around resources for us to be able to kind of scale this effectively. Clearly, there's a lot of scrutiny from the Welsh Language Commissioner, and that's not just for us as a health board, it's I think across health and social care and across the public sector in general. You know, there are a lot of standards against which we need to comply, and some of those can be quite, you know, you can easily make a mistake by, you know, a misconfiguration of a letter template, and then you can have a compliance notice against that. So these are things that we really need to address and to fix. But yeah, I guess our annual report has recognised, you know, our strengths of what we've achieved over the last year and our aspirations about where we need to move going forwards. But yeah, I think there is a positive relationship with the Welsh Language Commission, and there's perhaps that practicalities of where we are now and where we need to be over the coming period. The first thing, workforce digital risk register, Rena kind of picked up one of the points around where obviously, which is the 3 risks that exceeded our appetite threshold. So particularly around recruitment and around nurse staffing levels. Obviously, that's under close scrutiny for the workforce and the digital committee. And there is a meeting next week to further look at that. And I won't go into too much detail with everything else on the report, apart from just to say we've had, ever since I've been on the committee, and certainly since I've been chair, we've had a lot of attention on statutory and mandatory training and PADR compliance. And I think it's really important to recognise that we have made massive efforts to improve that, and some quite specific and targeted interventions. And we're, you know, the Health Board is ranked first in terms of stat and man training compliance in Wales. So I think that's something that I'd like to formally record with the board.
Thank you. I pick that up. I think this is, you know, it was a long standing, this is very good. Any questions for Tom? Let's start with the Welsh language, what you were saying, and appreciating that the resource implications are very challenging. Do we have a robust plan and they prioritises the key areas at risk?
I'm going to the next Welsh language group to consider, as Paul said, there's 121 standards, some of which are easy and straightforward to comply. And I think there's probably about 30% that are more challenging and require long-term consideration around investment and how we work with it. So the Welsh Language Group next meeting is not to consider those and think about the plans and identify the risks in achieving them. But okay, that's great, thank you. Okay, if we're happy with that, let's move on to the COVID inquiry digital.
So we took this paper to all the committee earlier on this month, so we've already had some robust conversation. So I'll just give you the highlights. So the issue arose earlier on in the year where it was identified that our national Office 365 environment had a flaw. There's a configuration issue with it where we were deleting inactive inboxes. Staff who left the organization automatically being deleted after 3 months, even though they should be kept for 7 years. This was a configuration issue nationally, only affecting inactive inboxes, not live inboxes of permanent staff, it has to be said. And so the effect was national. The issue was temporarily fixed February the 20th and resolved fully by March 2023. However, those inboxes that were deleted are not recoverable. There are a decent number of those, including our former chief executive at the organisation in 2021. And the main risk, of course, is our inability to react to requests against inquiries. For example, the COVID inquiry has the title of the paper. Mitigations that were taken. Well, first of all, we had a good mitigation in place anyway, because throughout the whole COVID period, we set up a COVID mailbox where all emails pertinent, all correspondence pertinent to COVID. The process was that mailbox would be sent those emails, and we ensured that mailbox had litigation hold applied to it, so we could not lose that mailbox. We've also since put an extra layer of protection against mailboxes of senior staff of the organisation. Not that we're expecting anything to go wrong nationally now, because it's been resolved. We do have an extra layer of protection for senior staff locally. From a DHCW perspective, as well as fixing the problem, they've also asked Microsoft to do a full review of tenancy that we have nationally. A number of other recommendations as well in the appendix that we've attached that DHCW is taking forward. And I've had a recent update from DHCW where I'm assured that they are carrying out those recommendations. A lot of those have been completed already. With probably the most important one, the Microsoft review, which will complete by November. That there have been a number of actions that since made on that action. So, yeah, it was a significant issue. It's been resolved. Lines down. Thank you.
So, as Matt said, we spoke about this in some depth in the audit committee, and yeah, I think it's clearly unfortunate from a public perception perspective. You know, we don't want this to kind of propagate any, I suppose, conspiracy theories about information being deleted. But I think it's been a really positive response, and we can demonstrate that the process and the order that's been in place around the mitigation. And I guess since this is a national scale piece and just Swansea Bay, I think it's pretty clear. It's a really positive approach. I think the recoverability is also the steps to identify emails that can be recovered from other inboxes is really positive too. And clearly the potential punishment under the Public Inquiries Act is obviously quite significant, but I think we can get on the front foot when and if there are any issues about this, demonstrate what's done. So I think it's a great response by certainly by the Swansea Bay team, but I think by DHCW to address this quickly.
Good. Thank you, Steve.
Couple of questions back. The recovery process, are the HCW doing it with their own resources, or are they getting expert advice? Because my old firm, for example, they had forensic people that could find emails wherever they've gone, find attempts to delete them, burn them, whatever. And you mentioned that, Peter mentions a health board. So all members cannot delete their emails. Does that include our executives? And if I delete an email, which I just did, where does it go? It wasn't anything to do. Is there a repository of emails that we delete?
Right, so your first question around you had expert advice, so they work closely with Microsoft on this, who, you know, Office 365 is a Microsoft product, and yeah, it can't be recovered. You should have had that set all along. That was upon advice from another third party that worked with DHCW when we configured it in the first place. Well, can't use anymore. They now adhere to the 7-year rule, but we can't recover those. In terms of the senior staff that we turned on this litigation hold for, that does include independent members. And yes, when you do delete an email, it isn't lost, it is stored somewhere in that Office 365 environment. If you want a more technical answer, I'll get back to you on that.
It's quite enough. Thank you.
Sorry, there's one thing I forgot to mention, that there was the interesting consequence with regards to things like subject access requests and FOI requests, because actually that probably adds an extra layer of complexity about if we are trying to, you know, fulfill our requirements under the relevant legislation, then that's going to require sometimes interacting with DHEW at the national level as well.
Right, okay, so it's clearly been really thoroughly.
Yeah.
And what we agreed,
Which is appropriate for experience. Good.
what we agreed in audit committee is that we make sure that we've got a solid process in the organisation that all relevant people understanding how to request this this process by DHEW to search national inboxes.
Very much, Matt. Thanks for the work on that. Okay, so hang on. There we go. So we are now on the Welsh language standards annual report.
So this report presents the annual approval and regular publications, which is September we do. I think we heard from that story and feeling out today how important the use of Welsh languages for our patients. We just touched on in terms of areas of non-compliance that we need to improve on the support that we put into the Welsh language group. And I think I just want to place on record in the thanks to the Welsh language officer and team, which is important. It's a really good report and they really do a lot of good work, which is identified in the report. That's all.
Thank you very much. Any questions? Yes, Jackie.
Yeah, I just wanted to ask, I noticed in the report that obviously we've got some kind of tools to help staff, some common phrases and some videos. But obviously listening to a Larry, a patient story, and heard the example of a patient and his wishes. It's not the same as being able to hold a conversation. And in the report, there was a bit about recruitment, and that there were 6 posts advertised where Welsh was essential. So is it restricted, the number of posts we can put out that are, you know, restricted to must be Welsh language speaker, or is that something that we can expand a bit further, more than desirable then?
Yeah, not restricted, but I think there's that balance in terms of the workforce that is available out there really to apply for these posts. And I think in some areas, you know, we've heard that we've had to go overseas really to gain, you know, and recruit to areas. So I think it's that balance really, and I think probably having it as desirable then stops us limiting, I guess, from recruiting to posts where people who would apply, but they can't speak Welsh, so they're not applying if there's things essential. So it's that balance at the moment, but I think you know, there's commitment, isn't there, as a national country to have more Welsh speakers really, and I think it's part of the Welsh language officer's intention to start going up to Welsh schools and just encourage them, say, you know, there's lots of jobs available, it's not just nurses and doctors, there are, you know, administrators and support workers as well. So just part of a bigger picture that we're trying to encourage Welsh speakers to find vacancies. But we're not restricted. It's a long answer to your question.
And just to follow on that, so some of the sort of strategic progression of the more than just words frame for Welsh language services and health, social services and social care. There will soon regulations are coming in to have more jobs advertised that will require Welsh language as essential as well as desirable. So I think we are aware of that as a roadmap over the kind of coming 2 or 3 years. But I think there is a pipeline kind of capacity problem with this too. So yeah, as Hazel said, I think that working with local FE colleges and tapping into the Welsh medium education sector to think about that pipeline of you know, bilingual expertise is going to be really, really important for, you know, our local jobs market.
You know, I may have missed it, but I know we're doing a lot of training and trying to get people whatever. But is there mechanisms within the organisation to actually have informal conversations and practice? Because as an example, I think the only way I'm going to speak Welsh more is to speak it. And the bottom line is, you haven't got anybody who you can speak to, you're struggling, aren't you? even if you're on a course, outside the course, you're distracted. So I just wondered if we got mechanisms, why, you know, coffees together to speak Welsh and that sort of thing, or whatever. Yeah.
I think that's a really good point.
Thank you. Okay. So we now move into, there's been no population health and partnership committee, that's coming up soon, so after the next board. We move into part 6 governance, and starting with the keys to support mental health legislation.
Yeah, thank you. So as the board is aware, this committee deals with compliance with specific legislation dealing with mental health issues, although inevitably goes sometimes into issues of performance and quality. So forgive me if I do that now. So you'll see in the report compliance with the Mental Health Wales measure of 210 is generally good, but as we've heard in other parts of the meeting, we've inherited a service, the CAMS service, from another health board, and their compliance has not been as good as it should have been. So that's one of the management problems that we have in that new service, and something which is really on reflection a quality issue rather than a compliance issue, but was brought to this committee because it's a mental health matter. Was a report that HIW did into our CAMS service again, but specifically the transition between child and adolescent to adult in mental health services. Now, this was done while the CAMS service was still under COMTAF's aegis. The report then was dated in May when it moved over to us. So we pick up responsibility. There are 6 assurance objectives. 3 of them were marked reasonable. 3, however, were limited. And the specific areas that they were limited in actually relate to our Ward F. Ward F, as you know, is a mental health facility in Port but the Port Hospital, but it has a child designated bed there, and the issue seems to be around governance, around the training there, but in particular the DBS regime. Everybody that deals with vulnerable people is supposed to have disclosure of barring status clearance, and not all of our people did have, which, given the vulnerability of the people involved, is I think a fairly serious breach. So that's being addressed, and luckily the auditor from, sorry, I said HRW at the beginning. I meant the internal auditors. The auditor was there in our meeting, and he assured us that there was good cooperation from the service and that he was happy that progress was being made. So that is being dealt with, and I think we'll pick it up again in Mental Health Committee next time round. Once we've looked at it once, we may as well see it through to its conclusion. We have, as ever, an issue with the best interest assessors. That, however, is improving. We have got more of them now. They've been working some overtime, and we got some additional funding, and there was an external provider as well for a period. That's now finished, but they got through the backlog quite a bit. It's still a risk, but it's getting better. And you'll be aware that I've told you before, the liberty protection safeguards that were due to come into effect, well, originally last year, then this year, will not now do so. So the old DOLs, the deprivation of liberty safeguards, they remain in place, and so we have refocused our resources to deal with that backlog and getting those procedures up to scratch. And that's all I need to say.
Any questions for Steve? I have to say I was pleased to see the best interest assessment position, but it looks like funding's now gone. Are we now on an uneven keel?
That additional funding has gone. I think we're probably two business assessors lighter than we'd like to be, and we don't
Not
have
better than
funding.
we were, but it's bad, I feel that.
Really, I think that's a very excellent thing to there. The real challenge around the lifting pressure safeguards not going ahead is how we have to regroup everything now, back around these areas. The service had about 400,000 investment last year. And I still think we were in the process right now, that will enable us to get to the majority of the assessments. But as you said there, the key thing is that we continue to monitor this now and are really tight into this and knowing what our thresholds are. And we went over previously that we can't go over again.
Okay.
That doesn't negate the fact that if we do get into that cycle, we may be looking to see how we can enhance that team further financially. But I don't think we're there yet.
Okay, good. Thank you. Fine, okay, so we now move on to the next, which is the charitable funds committee.
Chair, before we move on to this, in the interests of transparency, may I please make the board aware that I undertake a voluntary role as an ambassador for the Teenage Cancer Trust in Wales. And one of the items that we discussed is the teenage outreach, which we work for in terms of the unit at Beacon Cardiff. So not employed, but I do think in the interest of transparency, I should make.
Thank you very much, Jean. Thank you.
The report is there to note, I would like to alert you that we have closed the Helping Hand Fund to new bids. There's no more money in the pot. However, the charity team is helping people seek alternative funding for their ideas. I'd like to assure you that the charity's business case and governance arrangements will be linked to a clear financial plan. Business case will be discussed at the next trustees meeting, and inform you that the board that we expect an increase in requests to the charitable funds for funding as a consequence of the health of its tight financial position. And assure you, as a committee, we are keeping a tight focus on ensuring that we do everything that we ensure that we support core fund, that we're not supporting core funding activities. I think that was all I intended to say, unless there are any further questions.
No, thank you very much. No, thank you. So we've got a charity, we've got a trustees meeting coming up.
The business case.
Great, thank you very much. Okay, now on to Hazel, the report on corporate governance.
So provides kind of matters considered in the board meeting, the update on Welsh Health Circus, business cycle and common register as well. There's two areas for the board to consider and approve, which is the committee's annual report and also the model standing order and funding financial instructions, changes set out on page 3 and 4 of the report, and happy to take questions.
So any questions for Hazel? Are we happy to approve the committee annual report? Yeah, and the changes to the standing orders. Yeah. And while I'm at it, I didn't formally ask, I'm assuming that we were happy to approve the Welsh language annual report as well. Great, thank you. Okay, summary reports from the board advisory groups. We'll start.
So two of them left. Stakeholder reference was meeting was on the 22nd, so that was back to the next board. Health Professionals Forum, they received a presentation on salary development, presentation on population health, and they discussed their operation arrangements, duties, and memberships. In terms of the Health Board Partnership, there's an update on the pilot scheme of the continuous flow model designed to increase capacity and remove pressure on the front door. And they also had a presentation on the duty of candor and considered an update on rostering policies.
Thank you very much. Ben, you want to add?
No, not particularly right where we've been. I think our focus as we move forward into the year, though, from a health professionals forum, is to work with the Karen's team terms of having input, clinical oversight and view around the sustainability plan or annual plan going into next
Yeah, yeah.
year. Making sure we're very much part
And
of
your
that.
point about getting involved earlier in the process, is there anything we can do to support that in terms of, that's going to be worked through Karen, is it?
So that's what we're doing. So our next meeting is a workshop style meeting with the planning team, so we can look at how we can input and support and provide assurance or challenge and scrutiny around how the plans develop.
Great, thank you. Thanks very much. Great. Okay, is there any other business? No.